Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome to the program Dr. John Mansueti. You are the Medical Director of Radiation Oncology Clinic at Peninsula Regional Medical Center and also a Cancer Liaison Physician. That's quite a lot of titles there, and you're here to talk about cancer care update for the Shore. So first, explain to us, what's going on at PRMC. There seems to be a reorganization and expansion of cancer care services, and you seem to be at the hub of that.
Yeah, well, thank you very much. Thank you for the opportunity to speak. So, yeah, we got a lot of exciting things going on at PRMC right now for the cancer care. We recently opened a new breast center on Snow Hill Road. It's been operational now for a few months, and it's a nice concept where a woman with maybe an abnormal lump or they had an abnormal mammogram, they can actually go to one-stop shop. They can get the diagnostic test they need to evaluate it. They can actually get the biopsy on site. They can meet the surgeon on site. The actual surgeons that do the breast cancer will be there on site to evaluate it. They can have real-time read on their radiology image and speak to the radiologist directly on what the findings were. And so it sort of speeds the whole workup process for a patient that finds a lump to evaluation, to imaging, to biopsy, meet the surgeon, and come up with a treatment plan, sort of an all-in-one stop shop. So that's really exciting to have that. We've been working on that for a while.
Well, that seems very convenient, and you don't necessarily have to go to the hospital then,
Exactly.
The campus of Peninsula Regional to have all this done.
You're not driving to 3 different doctors' offices. You go to one spot, and the doctors and the imaging all comes to you in one location.
Well, that sounds very exciting. I know you have some other big news, but before we get into that, I would like for you to talk to us about just all the changes in cancer care, all for the better. How has cancer care changed these days?
Sure, absolutely. Well, it's incredible how fast things are changing in oncology. And sort of the triad of cancer treatment is surgery, radiation, and chemotherapy. And all 3 of those areas are changing dramatically. I think you and I were speaking earlier about breast cancer is a good example. Surgical techniques are constantly changing, updating. Surgeons are doing nipple-sparing mastectomies now where you can't even tell the patient ever even had surgery after they're completely done and have all their reconstruction complete. It's really amazing. The chemotherapies, the targeted therapies for breast cancer are constantly evolving. It seems like every week we get a new drug that comes on the market that can treat patients that may have not responded to their initial treatment. So that's quite exciting. And then in radiation, we're constantly changing our fractionation, how quick we can do the radiation. And now, pretty much most patients were stuck with coming to my department for 6 weeks to get their radiation for their breast cancer after they, say, had a lumpectomy. And nowadays we can get that down to 3 weeks, and a lot of patients, and some patients, if we use brachytherapy, they can get their radiation in 1 week. So pretty dramatic changes as far as convenience for the patient just on the radiation side for breast cancer. And not just breast cancer, all areas we're constantly making new changes, updates, and patients are living longer. We are really winning the war on this.
And age is a risk factor for many cancers.
Oh, absolutely. I mean, that's the biggest risk factor, really. If you live long enough, you're probably going to get cancer. And, what is cancer? Cancer is a mutation in your DNA. And the longer you're alive, the more chances you're going to have for your DNA, sorry about that, to have that defect. And so, like I said, if we live long enough, we're all going to get it. As a woman, I think they say the latest 1 in 8 chance that you're going to get a breast cancer, and it's typically older women, but we'll have very young women who come with breast cancer, and typically tends to be more aggressive in a younger woman. We have to be very aggressive and do everything we can to try to cure that patient very aggressively for the young patient.
Yeah, that's where I think people get misled, because you hear more about the younger cases that are more aggressive and often don't have the best outcomes, but actually it's older women that account for the majority of the cases.
Absolutely, absolutely, and they can get very aggressive breast cancer too. But we stage everybody. We do all the evaluations. We do the very thorough pathologic evaluations to try to determine exactly how risky and what subtype of breast cancer you have to tailor the therapy to that exact cancer.
Yeah, I wanted to ask you about that targeted therapy. If you give us a good example of that, because that seems to be the really big development.
Yeah, I mean, actually, one of the sort of historically, you could almost think one of the earliest targeted therapies was the drugs for the ER positive, estrogen positive breast cancer. I mean, we've known this for a long time. Just using hormonal manipulation, you can keep those cancers under control or improve the chance of curing somebody with that. Other targeted therapies for like lung cancer would be an ALK mutation. It's a specific mutation that certain lung cancers have. It's not very common, but if you have it, we have a specific drug that can target the exact sort of process in the cell that's been turned on by this mutation. And this drug tends to be much better tolerated than a chemotherapy, and it generally only sort of affects the cancer that has that mutation, and whereas your normal cells tolerate it, much better than, say, a chemotherapy. So it's kind of exciting that we can, give you a pill or maybe an IV, injection every few weeks and specifically target that cancer itself rather than causing sort of a systemic treatment of all your cells.
Right, and that way you don't have some of the side effects that you can have with the more toxic
treatments. In general, tends to be better tolerated than some of the cytotoxic chemotherapy. Now, there are some side effects to these, but they tend to be less intense and better tolerated.
I know you're seeing more commercials about them too, these targeted therapies.
They're marketing directly to the patient now, which I think is quite interesting. And I just saw a commercial yesterday on immunotherapy. They're targeting that directly to the patient now, which I think is quite interesting.
Talk a little bit about immunotherapy.
Sure. Immunotherapy is sort of the new kid on the block, and that is actually using certain drugs to manipulate your immune system to attack the cancer itself, and in some cases we think maybe even cure the cancer completely. And these are patients that often have very advanced cancer that has spread throughout their body, and if they get one of these drugs that can help your immune system sort of wake up and realize that that cancer is a bad guy, it's able to go in and attack that tumor. One of the drugs that you see advertised, Keytruda, I think, is the one they're currently advertising. There's a thing called a PD-L1, mutation. If you have that, it directly affects that part of the immune system. It kind of sort of wakes up your immune system to attack that cell, and it's very complicated, the communication between your immune system and the tumor itself. But you can almost think of it as an uncloaking mechanism where the tumor is kind of able to hide from your immune system, and these drugs, you can almost simplistically think they just kind of pull the cover off that tumor, and all of a sudden your immune system recognizes that as bad and it's able to go to attack it. That's sort of a simplistic way to think about it. The other way is to think about it is your immune system's kind of like a car that has a gas pedal and a brake, and so your immune system, you can put the gas pedal on and make your immune system much more revved up to attack, or you can push the brake and slow the immune system down. And your body has a very intricate system to kind of keep the checks and balances so that your immune system doesn't attack your own body. You hear of autoimmune diseases like lupus. That's where your immune system's kind of attacking your own body, or MS, multiple sclerosis. And so there's going to be a very intricate balance between being aggressive enough, but not too aggressive that you're not starting to have your own cells, normal cells, attacked. So these drugs are pretty good about sort of allowing it to attack your cancer, but not be too aggressive where it's attacking your normal cells. That being said, one of the side effects of some of these immune drugs is that you can have it go kind of a little bit too overboard and start having side effects in your lung, your gastrointestinal tract. So the medical oncologists have to be very attuned while the patients are on these drugs to make sure they're not having these side effects, because if they are, they have to stop the drug and start you on steroids typically to kind of slow things down again.
Right. I guess that can be an individualized thing, right?
Absolutely, and you can't predict. You can't predict
and
who's going to have this.
As people age, their immune system isn't as strong, and so I guess you have to tailor it.
And interesting, there's not a good sort of test or biomarker for me to determine if I know this drug's absolutely going to work on you or absolutely not going to work on you. So a lot of times we we need to try them in almost everybody that qualifies. You have to have certain characteristics of whether you can get these drugs or not. But there's no great prediction whether it's going to work or not work.
Let's talk about what are the common cancers you're seeing on the shore. You said there's a top 3?
Yeah, our top 3 would be breast cancer, of course, prostate cancer, and lung cancer. Of those 3, the one that's a big killer is lung cancer. That's the one that, even very early stage patients, if you look at all comers for stage 1 cancer, which is the absolute earliest, the 5-year survival is still only about 50% of the patients. So even at the earliest stage, now that's not all those patients that die in lung cancer, because they tend to be older people that got lung cancer, but the overall survival is about 50% for stage 1. And now as the stage 2, 3, and 4, that 5-year survival drastically decreases. So a stage 3 patient, they may only have 5 to 20% 5-year survival, depending if it's stage 3A or 3B, and much worse for stage 4. Obviously, very few patients that present with stage 4 lung cancer. And when I use the word stage 4, that means it's gone from the lung and spread elsewhere, maybe to the brain or to the bone. Those patients, almost none of those are alive after 5 years, unfortunately. But with these new drugs, these immunotherapies, we're excited that maybe we may be able to turn that tide. And even patients with very advanced cancers, we're seeing some really promising results, living much longer than we used to see in the past.
Well, the other good news about lung, there are cases where people will get lung cancer without ever having smoked, but at the same time, smoking's a huge risk factor. If we could cut back on that, that may help the incidence of lung cancer.
Well, I tell everybody, if I could get everybody in this country to quit smoking, to drink moderately, but don't drink too much alcohol, and also watch their weight and have a healthy lifestyle with nutrition, that I swear about 30 to 40% of my patients would just disappear because they...
In terms of not having cancer.
Not having cancer. Yeah, exactly. Because the majority of our lung patients are smokers, but we actually absolutely do. In fact, I just saw a patient recently that was a non-smoker his whole life, and he had lung cancer. And so we do see it, not as often. Radon exposure, we think, might be part of that, and secondhand smoke, maybe a part of why that non-smoker all of a sudden got lung cancer.
Can there be a genetic predisposition
Absolutely,
to that type of cancer?
Absolutely. And then, your lungs are big filters, so we're breathing in everything. So, that person may have just breathed in some carcinogens that, from pollution or whatever, and they just were unlucky.
Mm. Now, I noticed colorectal cancer isn't in the top 3. Is part of that because of the screening, the success of the screening?
Well, a lot of times you would think the numbers will go up if we screen because we're going to catch it. So it's just not as common. I mean, women, you have the exposure to estrogen, so that's a big exposure for the breast cancer. Men, we can sort of just, if you have a prostate and you live long enough, you're probably going to get prostate cancer with exposure to testosterone. And then, lung cancer is because we have a fair amount of smoking here on the Eastern Shore. So that's pretty much why the top 3. I've looked at our numbers. Our rate of colorectal cancer is really no higher than the rest of the country. We actually are a little bit higher on melanoma, actually, than everywhere else. Yeah, I mean, we're near the beach. Could it be the sun exposure? Do we have an older population?
Watermen,
That's why watermen, farmers, that sort of thing. So definitely we have a higher rate of melanoma. But most of the other cancers were fairly close to the national average. When I first got here, I thought we had a really high rate of pancreatic cancer. It seems like every week we were talking about a new patient with pancreatic cancer. I did go back and look at the numbers, and I think we're fairly close to the national average, maybe a little bit higher than the national average on pancreatic cancer. But that's another really bad one that I think we see a fair amount of here.
Yeah. Now, one of your positions is cancer liaison physician, and I believe you wanted to talk about how cancer care has changed in terms of a multidisciplinary approach, getting care from several different professionals, of course the physician leading the way, and then having more of your care in one place, like you mentioned with the Snow Hill Road Center. So talk a little bit about that.
Sure. In the old days, if you had we'll use breast cancer as an example. You found a lump, you'd go to your surgeon, and he would take the mass out, and he'd say, well, I think you need some more treatment, so let's send you over to this radiation doctor or this chemotherapy doctor. But it's sort of after the fact. Nowadays, what we try to do is we have what's called a tumor board, and all the physician specialists, and this is what I'm talking about, what we do at PRMC. We basically get in a room, once a week, and we talk about every patient with that cancer. Yesterday, we had our lung cancer tumor board. And every patient that was recently diagnosed with lung cancer, we would sit down, we'd look at the patient's images, we would review their pathology with a pathologist. We'd have a radiologist actually looking at the films. We would have a medical oncologist, a surgeon, a radiation oncologist, a research nurse, all in the same room talking about that patient. And we would come up with a plan prospectively how we think is the best way to treat this patient. And that is exactly the way you want to do it. It's been proven time and time again. That gives you the best outcome if you have a multidisciplinary approach where all the experts on that cancer come together, put their heads together, and figure out what is the best way to approach this patient with this cancer.
Well, coordinated care always seems to work better than the disjointed care or care in silos, per se.
You're right on the mark.
So we have this breast center in Salisbury on Snow Hill Road. I know you also wanted to tell us about another new development.
Yeah, so in July we are supposed to open our new cancer center in Berlin, Maryland. It's going to be near Ocean Pines on 589, and it's scheduled to open, I think July 5th is what our current schedule is. We will have on-site radiation oncology and medical oncology all in the same building. It's about a 20,000 square foot building. Medical oncology is going to have 12 chairs for chemotherapy patients. We're going to have a linear accelerator there for radiation, and lots of other office space. We're going to have telemedicine, conferencing capabilities. So the patients that I see there, I'm going to be able to present them at the tumor boards that we have back here at the mothership. So I will still be able to have those patients presented to the surgeons, the radiologists, the medical oncologists, the research nurse, all right there in that same tumor board, but we're going to do it virtually. So I will be in the site in Berlin. The docs back here will see everything that I see. I'll see everything they see on the screen. So that we can still keep that multidisciplinary care, but remotely. And so I will be able to have those patients have sort of the expert opinion of all the physicians here at PRMC.
Of course, that makes it much more convenient for people on the lower shore then.
Correct. Yeah, I mean, say a radiation treatment for prostate cancer, that's 8 weeks of radiation Monday through Friday daily. And to not have to drive, 45, 50 minutes here to Salisbury when you're 5 or 10 minutes away from the new site is huge for the patient, especially when you're not feeling well, you have some side effects from the chemotherapy or from the radiation, and to not have to sit in a car for 50 minutes is a godsend for some of those patients.
Absolutely. So that sounds very exciting, and it sounds like it's part of Peninsula Regional Medical Center's initiative to keep people on the shore to get their cancer care.
Correct.
Because you're saying the equipment, you have all the same equipment?
We have the latest and greatest technology you can buy. We have the same technology that you can get at University of Maryland or Hopkins. We have extremely well-trained doctors here at PRMC. And you're really not going to get, in my opinion, better care going to the Western Shore. When you're not feeling well, to be able to go to sleep in your own bed every night is huge for the patient. And to have the family support while you're getting treatment is very, very important. So to be able to stay locally for some of these patients really makes their life a lot easier.
Absolutely. And of course you have the Cancer Care Center located on the premises of the hospital.
Absolutely.
So what we'll do at the end of the program is post the website for PRMC. Of course, you said it's under construction, or you can still go in, get the phone number, and call if you have any questions about the Cancer Care Center.
Absolutely, absolutely.
Well, thank you so much for being on the program and letting the community know about all these exciting developments.
Thank you very much.
And thank you for joining us for this edition of Focus on Health here on PAC 14.